Hello, it's NP Table Talk with Lala,
Christy.
Margie.
and we're here today with Dr. Lee with Vascare, and
How's
we're
it
going to
going?
go ahead, and we're going to go ahead and let you kind of introduce yourself and tell us what you offer here at Vascare.
Well, I'm a vascular and interventional radiologist. Vascare is an outpatient vascular and interventional center where we offer minimally invasive procedures, clinical workup, and diagnostic workup of patients for a variety of vascular type conditions. Some of the more basic are venous and arterial, but there's also some very cutting edge outpatient embolization care that we offer. I think we're going to go into that a little bit, but things like uterine fibroids, arthritis and knee pain treatments.
Awesome.
Yeah, that's great.
So what are we going to start with first? I guess I'll go first. I like going first. All right, Dr. Lee. So you mentioned like PAD or peripheral arterial disease. Do you think here in South Texas we have like a large need for that?
In South Texas, this is actually one of the highest amputation areas in America. There's a metabolic crisis that's ongoing here within the coastal bend and this entire region of South Texas. It's more than just diet and lifestyle. There's a lot of genetic components to the type of people that live here over the years. And some of it also has to do, I think, with economic factors. They're just not seeing enough primary care physicians or nurse practitioners to get the type of preventive care that they need. As a result, they present late, and with their late presentation, it leads to amputations.
But if they do come in time, you can do a balloon, a stent.
Yeah, it's a kind of a collaborative team effort. If they're working with their primary team for early diagnosis of the risk factors, things can be mitigated where they don't even maybe need to see a vascular specialist. But when they've progressed and developed disease to the point where they're starting to be very symptomatic, early on, you can make small changes in their system, things like angiograms, angioplasty, stenting, that preserves their long-term vascular function, saving their limbs. And there's a saying: you save a limb, you save a life.
Yes.
If you get an amputation, the mortality rate within 3 to 5 years is almost 80%.
Wow, that is so true. And you could do those procedures here, correct?
Correct. With the growth of technology, just like your Apple Watch that you just had there for a minute ago, a lot of the medical devices and the technology we have is so advanced now that it's safe and it's more efficient, both from a value perspective, financially, as well as from patients' time, that we can do it on an outpatient basis and have as good, if not sometimes better, outcomes for patient care.
Yeah, it's hospitalizations, and then of course,
Constant
high
care,
risk. Yeah, then just high risk of getting pneumonia.
And that healing time is very good for sure.
Oh, that is
so. Thank you.
great to hear.
Yes.
I think Margie had a couple questions also.
Yes, Doc. I saw that in one of your brochures that you treat knee pain and inflammation. Tell me more about your genicular artery embolization.
Well, this is actually a fascinating new procedure. It's about 5 years old or so here within the United States. It's the fastest growing vascular outpatient procedure in America. There's sometimes 3 to 4 month waits at some of the major cities like Houston to have it done. When you get a little bit of cartilage injury, you release what are called cytokines, which cause the growth of new bone structures like bone spurs. And with that comes the growth of new blood vessels called neovascular growth. That leads to new nerve growth. And it's those new vascular structures and nerves that is what leads to knee pain. And you can, with the orthopedic surgery, you can often fix the underlying structural component, but it doesn't always fix the pain. And so even after knee replacement, patients continue to have pain. So by going into the blood vessels, and just like we talked about the advancement of technology, some of the microscopic size particles now that we have, we can just slightly trim off that extra blood flow around the knee that's causing the pain. And it, for the lack of a better term, it kills off those abnormal nerves, basically taking that entire pain cascade away. It doesn't replace the need for a knee replacement, and it makes things like knee injections, steroid injections, or nerve ablations more effective because you're basically devascularizing a lot of the nerve bed. But the real best way to understand how well it works is to talk to patients who've had it. I can give you a myriad of patients, 10 out of 10 pain on narcotics, very difficult to manage. Their pain is limiting their activities of living, like truly living. They come in 2 days after the procedure, walking without a cane, 0 to 1 out of pain, and it's durable. It lasts years.
Okay.
And
So-
it's very low
It's a
low risk, right?
well, it's a low risk procedure. If it works for you, it works phenomenally. We've done about 40 of them. About 36, 37 have had a phenomenal result. There's been a couple that maybe haven't worked out from a pain perspective perfectly, but they didn't lose a whole lot from the effort. Insurance has been covering a lot of the expense.
Good.
But one thing that is important to understand is considered experimental, meaning it doesn't have its own CPT code, right?
Okay.
I imagine the next few years it will be approved by CMS and Medicare as a standard of care, just because it's such an amazing, and the outcomes are incredible.
Great.
So what patients would this be contraindicated, or you say, no, this is not a good choice for this patient? And to kind of further elaborate, which patients are candidates for this procedure?
Well, maybe answer that in reverse order. Patients with knee pain, right? Anyone that's having knee pain, especially palpable knee pain, something that's affecting their activity. Patients that are candidates would be patients that would be well managed with just kind of very conservative management. I have knee pain. I'm on a COX-2 inhibitor or some non-steroidal, and it's really managing my pain. Do an injection, and it lasts 3 months, and I'm fine. Maybe you don't need to have as aggressive of an intervention. So, but those patients that tend to be a little bit harder to manage, that are failing conservative treatment, especially the ones that are poor surgical candidates for a major knee replacement, those are the ones that I think are the best candidates that are out there in pain. They really don't have a good treatment option, or they don't want to have a huge downtime. Maybe they're an oil field worker, and if they are out for 6 weeks, this is a phenomenal option for them.
It's amazing.
That's a good service for sure. And then which ones would you say, absolutely not, I'm not going to do this? Just so that from a primary care perspective, like not even say that.
Well, I think the people that would be really hesitant to do the procedure on would be somebody with severe underlying peripheral arterial disease, which of course then we would manage their peripheral arterial disease.
Exactly.
Because the geniculates sometimes act as a bypass route around artery blockages. And then other contraindications are pretty basic. I wouldn't do it on a pregnant lady with knee pain. Maybe a teenager who post-traumatic, like if you just twisted your knee, you'd want to give yourself time to heal from that. You wouldn't want to necessarily go into an invasive procedure, but it's more of the chronic knee pain patients that just can't quite get to where they want to live it.
Well, the outcomes sound great from what you were saying. Like if you go to church and you kneel a lot, you have patients with positive outcomes at this point with this procedure.
Yeah, we were talking a little bit that we had a patient who said when she goes to church, part of their church service is they kneel, and she has not been able to kneel at church. And after this, she's able to, and that just transformed her life in a positive manner.
Yeah.
So,
that's amazing.
So then I asked her to pray for me.
I think we could always do that, right?
And now I'm having a podcast with 3 ladies. So
God answered your prayer.
Right.
So I had a question too. So what, as a of the primary care side, what kind of imaging would we need to order first, or before we think it's?
Well, at least here in our practice, all we want you to do is think about it, and then once we see the patient, we kind of tailor the imaging, because I find I get asked that question a lot. And you can order and shotgun a bunch of different tests and have a very expensive workup that half of it I don't really need. Okay. So if you think about it, think, oh yeah, you have a lot of knee pain or peripheral arterial disease or all these various things that we treat here, just send the patient and I'll manage the workup and be able to very limit that kind of more focal. Yeah. Versus if you shotgun a bunch of tests, MRIs and CT scans, it's a lot of expense for the patient that maybe they don't need.
Yeah, and a lot of radiation also. That's probably not necessary. Yeah.
So
that's neat. That's
just
amazing.
one more question, Doc. How about those patients who are obese? And
very good
does this work?
This is actually a better procedure for them, right? Because a lot of them, you can't get a knee replacement a lot of times unless you need to lose weight, but you can't lose weight because your knee hurts, so you can't really exercise.
Correct.
The way we can enter the artery, either at the foot or at the wrist, makes this a very accessible procedure regardless of patient's body habitus.
Okay.
So there is no real weight limitation, with the caveat that if you're maybe 500 or 600 pounds or greater, then you'd be better seen at a bariatric center. But
then they can come see you.
Yeah, then you come see you. That's a little bit of an extreme example, but
That's awesome.
But-
That's awesome. That's
you.
amazing.
Yes.
And so then I guess it's my turn. I want to talk a little bit more about the uterine ablation because
Okay.
I know we've had some conversations in the past about that. And we had a colleague who the daughter couldn't have a child because of the uterine fibroid.
Yeah,
and that was kind of out of the question for her at that time.
Yeah, she had symptomatic uterine fibroids. She was only offered a hysterectomy, which for some women is the right thing to do for them. But she was young and she had never heard of uterine fibroids. And when we had spoken about that, she was at one of the advanced nurse practitioner conferences. She became tearful and said, "I wish somebody would have at least offered this to us." Uterine fibroid embolization is a very basic procedure. It's been around for 30 years. I'm the only one here in the Corpus Bend region who's offering it as an outpatient, but it's a very common procedure done in all major cities in America. They do offer it in the hospital on an emergent basis. It's about a 2-day recovery. You're off your narcotics in 2 days. You go in through a pinprick of the wrist. The procedure takes 30, 45 minutes. At 6 months, when you survey women and you're blinded, you can't tell if they've had a hysterectomy or if they've had a fibroid embolization from a outcomes perspective. So if you're a heavy menstrual bleeding patient with fibroids, wonderful procedure for you. If you have a lot of mass effect, it's pressing on your bladder, causing frequent urination, constipation on your rectum, back pain, it helps shrink those. It takes a little bit longer from the shrinkage of mass effect compared to a hysterectomy, but at 6 months, based on these large studies, you can't tell the difference between the two.
That's amazing.
And just to elaborate a little bit more from the primary perspective, when I'm saying, okay, this patient has a fibroid and it's based on symptoms, is the treatment is what I'm assuming, not the size, or does the size matter as well?
Well, studies show that roughly 40 to 80% of women develop fibroids, and about 30% of the women with fibroids become symptomatic. So just because you have fibroids, whether you're an OBGYN doctor or interventional radiologist, you're not going to treat them unless they're symptomatic. When they're symptomatic, the size doesn't necessarily play a massive decision on whether or not they're a viable candidate. It's whether they're symptomatic or not.
Okay.
That's good.
That's
to
important.
know.
I mean, there's some nuances there. If fibroids are calcified, then they're not going to shrink with vascular, embolization. They're going to need a hysterectomy. If they're really, really large, I do let my patients know if they would just want to have a large bulk removal without waiting over time, then sometimes a hysterectomy is, a better option for them. I don't really think you should look at size as a reason to have one or not have one. I think it's whether or not it's affecting your life.
And I think you're always a straight shooter with patients and talking to them about that. And that's what I think we appreciate having you here in the Coastal Bend specifically, Dr. Lee.
And for any of the women providers that are involved in women's health, I'm very clear that hysterectomy is a safe procedure. It's the second most commonly performed surgery in America. Very well tolerated, a wonderful option. But this is just another option that a lot of women want to consider.
Yeah.
Yes.
You have to have choices.
Yes, for sure.
And one of the things to understand too is that I never promise a woman after a fibroid embolization they'll have their fertility preserved. But when you look retrospectively back, the fertility rate post uterine fibroid embolization is about 40 to 60%. The baseline fertility rate in women trying to have a child is 70%. So when you're young and maybe you have fibroids and you have some infertility issues, this still gives you the option to potentially have a baby. And so for a lot of women, that's important. And they don't necessarily want to have a hysterectomy.
Yeah.
That's
At
good to
least
know.
try it.
That's very good information. Thank you, Dr. Lee. So I guess the other questions, I know we also talk about venous insufficiency is a big one, and that affects all ages. I know young people that work out every day that may have that calf fatigue, that pain, right? It's something that happens very frequently.
Yeah, 40% of the U.S. population has symptomatic venous insufficiency. It's super common. I tell my patients, it's like you jump on a trampoline every day for 20 years. Pretty soon that trampoline loses its bounce. So the valves that are in your veins over the years, and really starts in your 20s, they stop closing. And when the valves of your veins in your legs stop closing, venous insufficiency develops. And then it's a slowly progressive disease. And then when you start to become symptomatic, there's a golden opportunity to treat patients before permanent damage is done in the legs. By the time you see swelling and that skin change, we call hemosiderin a deposition change in the legs, hemosiderin staining, they've missed their opportunity to be cured of it. And unfortunately, now you're mitigating and slowing down how bad they get. So it's a hard thing to pick up, but any patient that has a little bit of leg pain and throbbing, that's why you were asking, like, what do I need to work up?
Mm-hmm.
You know, you don't have to worry about it if you send them to a vascular specialist, myself, or somebody else in the community that maybe you're partnered with. We should be able to figure that out. You know, like, yes, you have symptomatic venous insufficiency, and maybe there's other things going on too, but it's a common process. People just don't think about it. They think it's a cosmetic procedure, but it's not cosmetic. It's a medically necessary procedure.
Yeah, patients
So,
that have cramping that bother them at night because of it. And so that's why I'm just like, yeah, that's amazing that, again, you can actually roll in and roll out arterial versus venous. And that's another plus in the community.
yeah, here we're kind of like a full spectrum, so you don't have to go to only vein, only artery, and then, you know, have 15 different appointments. But
That's nice. And then you have one physician that's, you know, which would be you, that's really like focusing on everything, like you said, versus, okay, this is my artery guy, this is my vein person, this is my cardiologist, this is my I mean, patients, they don't, I mean.
Yeah, I think that's a benefit here at Vascare, but it's not necessarily, you know, an infomercial for Vascare. It's like, it's more the disease process. So whether you send the patients to me or another vascular provider, we just want the patients to get to the right place, you know. Of course, I would like that right place to be here, but there are other very good vascular providers on the arterial and the venous in the community.
And that's knowing the signs and symptoms to look out for in the community on the primary perspective or the wound not healing perspective, those type of things that we can easily, I know I've had it and I've seen patients where they just have a wound that's not doing well, and we have a professional in the coastal bend that can evaluate those type of things promptly for the patient. And we appreciate it for sure. Just like you said, we don't want amputations, we want comfort, we want to increase the quality of life for all our patients, you know, and that's amazing. So thank you, Dr. Lee. And I think you spoke a lot about a lot of things that you do as an interventional radiologist here.
Yeah, I don't want to overwhelm people with so many different things that we do. I think the big takeaway is that we're an outpatient vascular center. If someone's having pain in their legs, you don't need to necessarily wonder, is it artery, vein, arthritis, things like, you know, we're just send them here and we'll help take care of the patient. And then we do offer these niche other practices that no one else is offering in the region, things like uterine fibroid embolization, the genicular artery embolization.
Yeah, that's
there's a few other things I don't want to overwhelm you with, but
it sounds like you're bringing a lot of great things to the coastal bend. So thank you, Dr. Lee.
Right.
It sounds like we might need a part 2 to this.
Yes, for sure. I definitely think so.
Part 2, let's do it.
Well, I would say thank you everyone for joining us, and I guess stay tuned for next time, and we will do part 2.
Yes,
Right.
absolutely. And
Have a good night. Oh, sorry.
we have
Okay, yeah, we'll follow us on Facebook at NP Table Talk or YouTube NP Table Talk, podcast NP Table Talk, or Podbean. I think I got them all. Or and you can also email us at nptabletalk@gmail.com.
Yeah, so if you have any questions, please give us all your questions so we can look them up and get the answers for you, okay? And do you want me to do the disclaimer real quick? Well, we can put it on the bottom. We'll just put
And also, if you have any questions, you know, for Dr. Lee, you can send those to us, and then we can have those prepared for next time, and at least give you what you want. Yeah.
Yes. Thank you, Dr. Lee.
All right.
Thank you.
Thanks a lot for inviting me on the podcast.
Yes.
Yes.
We're excited. Thank you.
Have a good night.
Bye.
Bye.